Prabodhini Saptaha series. The main aim of conducting this week is to provide knowledge and enhance the understanding of various concepts. It is my privilege to introduce you all to the eminent speaker, Dr. Devidas Jadhav sir, to enlighten us about his insight knowledge. He has been graduated from Mumbai University in 1998. He has specialized his practice in urology and andrology since last 23 years in Mumbai as well as at Satara and abroad. He is working at South Mumbai Advanced Urology System Private Limited, Sardev, as well as Harkisandas Hospital and Jaslok Hospital with senior professors from City of Mumbai. Presently, he is affiliated to Advanced Urology System Private Limited, SS Urology Institute, Pali Hill Road, Bandra West. He is an honorary guest professor at Savakar Homeopathy Hospital, Satara, for teaching medical students. He has also been visiting urology faculty to YMT Ayurvedic Medical College for urology services since last 2 years. Hereby, I now request Dr. Devidas Jadhav sir to guide us about today's session.
Thank you. Thank you very much. Is it audible?
Yes, sir. Yes, sir.
Yeah. So, okay. So my screen is visible to everyone.
Yes, sir. Yes, sir.
Okay. So can I start? Is it okay? Can I start now?
Yes, sir.
Okay, fine. So anyway, first of all, good afternoon to everyone, and thank you so much for it's a kind invitation by Atharva Council of YMT Ayurvedic Medical College, Kharghar, and certainly respected Dr. Sanjeev Yadav sir as a Dean faculty for Ayurvedic section and the hospital. At the same time, my colleague, Dr. Jaikini madam, Dr. Minal Vaidya, all senior staff, and Dr. Nishigandha Pool madam, she has invited and kindly gave me a call to invite on such a fabulous activity to deliver this particular little different topic that, sir, that you must talk in something clinical background. And this is Dr. Yadav sir's, you can say request or hut or whatever, that he said, sir, every time you talk so much about urology, now we are bored about urology, and now you must talk something which is going to do benefit to the student as well as to the our consultant, in order to how we can able to evaluate the patient when we actually see in the OPD, IPD, and we face certain calamities while diagnosing certain amount of elements. So you stress for this particular point that that what are the different investigations in clinical practice. So I made up my mind to give enough time to give a thought over it, and certainly put it into my best of knowledge of pathological investigations in clinical medical practice. So it is very vast topic, but my aim today and basic objectives, my basic objectives to cover up maximum uh, amount of investigations, at the same time to brief you all that how we can come to a certain amount of conclusion when you have a dilemma as far as diagnosis is concerned. One thing I'll tell you honestly, that it is very important that investigations is just for the help for the clinician and family physician and general practitioner and a consultant to arrive to a certain amount of conclusion. That's not the final soul of you know a tool to serve your diagnosis or to establish the proper medical treatment it will always help you out in order to when you are not able to come to a right decision. So it is very important. This is a supportive mode of tool for a family physician, that he has to confirm, she has to confirm by doing so that, boss, I'm suspecting infective endocarditis, I'm suspecting infective hepatitis, I'm suspecting urinary tract infection, I'm suspecting something, COVID-19 situation, I'm suspecting malaria, dengue, whatsoever. So, how I'm looking at this particular subject, what is my personal understanding and my personal assumption, that investigations in clinical medical practice is for confirmation of clinical findings. Definitely, which will lead to a clinical diagnosis, but it fully depend on very important part, this patient history, symptomatology, a thorough physical examination of the patient. Because what happened, all our youngster doctors, those who are just newly pass out or have a limited experience, moment the patient comes to in our own OPD, they come with so many reports, and we immediately saw the reports and prejudice our mind that this patient may have infection, this patient may have stone, this patient may have heart element, this patient may have sugar. Never do that. Always listen to the patient. What patient is going to talk about it? Any damn history. I came yesterday from village. I went yesterday with the puja. I went yesterday with the movie. Because patient is going to talk to you with his kind of suffering, with so much amount of concern, because ignorance is blessed. Somebody has said ignorance is blessed. People don't know that how to narrate. It is you as a primary physician that you can escalate, you can dig the history from his minor things. So it is very important that patients, you must listen to the first 5 to 10 minutes, you listen to the patient, provided you must have that much amount of patience to listen to the history of the patient. Obviously, then you must ask about symptoms. As I may always mention to you, symptoms, when it started, how it progressed, and all that. So onset, duration, and progress. And obviously, by looking up all these things, you must touch the patient from top to bottom. So general examination, physical particular examination, abdominal examination, respiratory examination, cardiovascular examination, CNS examination, lower limb examination, neurological examination. So all these important with respect to your vital signs. Now, what is vital signs? SpO2 saturation. How much is the saturation of the patient? The blood pressure of the patient, heart rate of the patient. So BP, heart rate, respiratory rate, and saturation is a key whole factor where you may have a standby. You may have standby about the patient is treatable in OPD, or patient will require immediate hospitalization, or you can still have a ample of time to make and establish your diagnosis. So vital signs are very important when you about to go ahead with certain amount of investigation. I hope is this clear. Okay. So all above factors which helps my family physician to arrive to certain amount of conclusions in order to decide the exact mode of treatment. Either it could be a medical, it could be a surgical, it could be an intervention or surgery, open surgery, but always it may require to a palliative mode of treatment protocol. Therefore, I feel personally, it's not only investigations, not only predict the better outcome for the medical treatment. Why we want to do an investigation? We want to decide what kind of medical treatment we want to give, whether we want to give oral medication, whether we want to start some IV infusion, we want to start some parenteral IV therapy, we want to, what. So it not only predict the better outcomes of medical treatment, but also determine the course of certain amount of illnesses. There are certain illnesses, there are certain sicknesses. It could be an recently diagnosed, or it could be an just originate. It could be just acute inflammatory condition. Or probably patient is just roaming around with couple of doctors, and then he comes to your OPD with some chronic inflammatory condition. So it is very important to determine the course of certain illnesses, whether it's acute or whether it's a chronic, or it's an acute or chronic and relapsing. So possible prediction of early suspicion in all this era, what you have to think as a primary physician, that you are not, because already there may be some sort of a complication which may have developed inside the body. Now, patient may have a long-standing alcohol. Patient must have having a pain in the abdomen going to the back and profuse vomiting. Patient may have some sort of a sweating. Patient may have fatigability. A patient may have some sort of an black stool. So what do you think in terms of? You may think in terms of chronic pancreatitis. But when you have a chronic pancreatitis, always you must think in terms of whether the patient has an acute relapse and patient is in phase of and developing some sort of a remote complication in terms of pseudopancreatic cyst or pancreatic abscess or renal failure whatsoever, or could be an what we can it may disturb the hematological profile and patient may go into a phase of DIC, discriminated intravascular clotting. So it's something what I'm talking, not all hi-fi things, but this is how you must have a sound medical knowledge when you want to do a proper investigation. Anything you want to do, you have to have some scientific background behind it. So therefore, possible prediction of early suspicion of remote complication of an underlying disease, one must ascertain or one must find out. So my aim has to minimize the rate of complication in order to do an early investigation, especially about obese patients, elderly patients, some sort of an comorbid patients, and early planning to initiate the availability of the best treatment options, which is currently available in the market for a speedy recovery of the patient. I hope all these things, all these what footnotes which I have taken out with my own experience in my clinical practice, which makes a lot of difference when you want to carry out investigations. Which investigations has to be immediate, which investigation which we can wait, which investigations which we have to do within few minutes, within few hours. So that's how. So as far as investigations are concerned, it's a long list, but in general, as far as our OPD patients and IPD patients, we have to choose certain amount of fluids. We have to take in the do the investigation through this particular media. Either it could be in blood, you have to withdraw microscopic or from the urine sample, from the stool, from the sputum, from the semen part, wherever the discharge of the body fluids, like especially pleural fluid, peritoneal fluid, cerebrospinal fluid, synovial fluid, pericardial fluid, and swab, which is very currently happening situation all over the world. Swabs, pharyngeal swab, nasal swab, ear swab, conjunctival swab, especially COVID-19 situation and pandemic situation. But swabs are very, very common. We have to take when your sore throat is not getting under control. It could be a long-standing chronic inflammatory conditions, Vincent angina, long-standing pharyngitis, could be early epiglottal malignancy, which we don't know. So it's a long way to go, but swabs has to be taken into consideration. Now, what I feel personally, usually I'm working in surgical field, so my experience is more surgical part. So how I'm going to evaluate my patient as per as pre-operative medical checkup? A patient comes to us, whether he may comes to you for a sebaceous cyst removal, or whether he may comes to you for appendectomy, or whether he wants to come for you for close reduction of ulna, or whether he wants to come to us for a removal of a small fragment which gets stuck up into the ureter, or he may comes to you for a prostatic enlargement to do a TURP. So in a surgical practice, what certain investigation is mandatory for appropriate surgical procedure is we have to have a medical fitness. Patient has to be fit for two things. Number one, what he has to undergo is a surgical stress, whether he can able to tolerate that kind of an surgical stress. And number two, someone has to anesthetize the patient in order to calm the patient and keep the patient sleepy during the procedure. So anesthesia point of view. So you must have that kind of a precise knowledge when a patient you want to screen and order certain investigation, not only to look from the basic point of view from stone or cyst or appendix or hernia, lipoma, or whatsoever the reason. You must have a basic tool with you where it is very important to you understand whether this patient may have anything else or whether I'm doing the right job and patient is having a normotensive investigations, which I can go ahead with my this surgical modality of treatment under all aseptic precautions, not to have infection during the procedure and after the procedure. So what you require is CBC, ESR, fasting sugar, post-lunch sugar, not in all patients, but it is a protocol. And obviously, if this FBS, PLBS, when you know patient is diabetic, you will ask for HbA1c. Now, I'll tell you honestly, I just posted my one patient about 10 days before with the request of Dr. Chavan. Dr. Chavan is a professor in Shalla department in YMT Ayurvedic Hospital. He's a very senior fellow. He has given me reference for right PU junction stone. But apparently, when we about on the day of surgery, patient didn't give an history, proper history, and patient has a long-standing sugar, which she is not taking medication from long time. So fasting was more than 200, postprandial was more than 339, 340 something. Now you tell me how I can operate on such patient, though the patient is posted for the same surgery for a right intrarenal surgery or breaking the stone on the same day and putting it in double gestation. I'm asking for a big trouble. I may perform the surgery very well. I can go ahead with my endoscopic tools, but I may land up with an septicemia, which I may not able to have and control in my hand. Procedure may be successful, but I may lose the patient. So then I talk to the patient, I talk to my colleague, and obviously my anesthetist is very fabulous, Dr. Naik. He said, no, nothing doing Devidas, we have to stop and get the glycemic control properly and get a HbA1c. And to surprise to your mind, HbA1c is up to 9. So whenever HbA1c more than 7, we cannot operate the patient. We cannot do any internal manipulation. It is a high risk patients. It is a high risk condition. So we have to get the HbA1c below 7, below 6, up to 6.5, and fasting is up to 140, 150, 160. Post PP is up to 200 is acceptable. We don't want PP to come too low because after post-op patient can go into an hypoglycemia. So it is very important. That's why it's not that when we do a surgery, when we do a surgical screening, we required a physician, we required a good anesthetist, we required some interim anesthetist, and we have a privilege here to Dr. Pandey. He always help us in giving a medical fitness. So thank you, Dr. Pandey, for choosing a right algorithm as far as to giving a right basic treatment in this hyperglycemic patient. So then we postpone the patient for a couple of days, and we are going to perform the surgery once the sugar is under control. CBC, ESR, FBS, PLBS, HbA1c, urine examination, very important. Serum creatine BU, and whenever you do any surgery, you must have sugar, you must have CBC, you must have urine, and you must have renal function. Because most of the time we don't know, older patients, they never know, but their creatinine is on the higher side, and you do this procedure and patient can go into some sort of an renal complications or metabolic complication. Bleeding time, clotting time, it is very important, especially in surgical era. How much is the competency of the blood? PT-INR, obviously when a patient has some kind of a liver disorder or history of alcohol, you must have a prothrombin time. I'm going to cover up what is the importance of prothrombin time. And obviously, as a very important tool all over the India, all over the world, that hepatitis B virus, HBsAg, surface antigen, HIV, SCV, and VDRL. It's venereal disease. So all these kind of triple H and VDRL reports is mandatory. And obviously, as a medical fitness, you must have an ECG and X-ray chest. If the patient age is more than 55, 60, having some cardiac illness, long-standing hypertension or DM, obviously you must get 2D echocardiogram in order to see the chamber abnormality. How is a left ventricular ejection fraction? How is a diastolic dysfunction? How is a systolic function? So whether the patient has any kind of vegetation, or what is the pulmonary artery pressure. So all these kind of an importance which you have to echocardiogram, and which is important is for an anesthetist that he may decide the type of anesthesia, whether it's a general anesthesia or spinal anesthesia or epidural. And obviously, in today's era, you must have an RT-PCR test for COVID-19 situation, because everybody's life is get miserable because of an this kind of a pandemic issue. Now, I think I'm going to do a basic information to you, CBC. Now, by looking at the CBC, what are the different parameters you are going to interpret? See, it is very, you must have read in this, you must have studied in your basic first year, your final year, but we forgot the basic, we forgot the common sense, and we always think something else. So I just wanted to summarize to you, I just wanted to revise to you, give some sort of an revision that, uh, in CBC, what you are going to look for it. So red blood cell cloud. What is the basic function of the RBCs is carry oxygen to most of the organs, many organs, most all organs. So lifespan of RBC is usually 120 days, practically 4 months. You see, so RBC destruction plays more into your RE system, more into the spleen. But whenever this particular RBC count, usually it's 2.5 to 4.5 million per cubic millimeter. When it is more than that, more than 5 million, more than 5.5 million, we call condition is called as polycythemia vera. And you hit this particular polycythemia vera and three important conditions. One thing is patient is dehydrated, where your RBCs goes up, your COPD, exacerbation of chronic obstructive pulmonary disease, especially in emphysema. You see a lot of COPD patient, if you do in their CBC, you always watch their RBC count is on the higher side. It's just because of they have more amount of retained blood. You see, they have more amount of retained blood. So COPD and tumors that producing more amount of erythropoietin. So there are certain amount of hidden tumors, those who have a predominant action on secretion of more amount of EPO, you may have polycythemia vera. So when you have more amount of RBCs, how the patient look like, how the patient present. So usually it's a hot flushes, red face, red eyes. Patient may complain to a headache, blurred vision, itchy skin. You see, so this is how we are going to look at this particular thing. And obviously, when the RBC count is predominantly less, we call it as thrombocytopenia. You see, or we can call it about RBCs. Thrombocytosis or thrombocytopenia. But the main ingredient of RBCs is hemoglobin, platelets, WBC, renal endices, different renal, red blood cell endices. So what is hemoglobin? It serves. I'm going to cover up shortly, not going into too much detail, but the hemoglobin in male is 14 to 16 gram. It is usual, 12 to 14 gram in female. And whenever we have a situation, hemoglobin is less than 7 or 6, we term that patient is significantly anemic. We have seen patients. I have done, a very my fortunate enough that now we have co-junction and very joint venturely practice together. Me and Dr. Sanjeev Yadav. Most of the time we are together. He calls me for consultation. I do a lot of consultation for him. But he is a massive, very famous, very reputed family physician in Parel village area. And trust me, in every evening he gives about 2 to 3, 4 patients intravenous orofor injections. I used to wonder how this anemia is so common, and this is what exactly I'm going to talk. So this is what I look at it with my own eyes when such a massive work he is loading about. So anemia is such a situation where all family physicians, they are going to come across, but you must understand where to give, what to give, and what you must have in your hand in terms of investigations. So when you have hemoglobin less than 7 or 6, patient may have fatigability, easy fatigability, shortness of breath, dyspnea. Patient may have long-standing anemia. Patient may have something called as high output states. Patient may require oxygen for a tissue to survive. Your oxygen is required, and hemoglobin contains oxygen carrying capacity of the blood. If you have less hemoglobin, your all tissues will not have, they will not have a proper oxygenation. So patient can go into a phase of we can talk about and something called as backward failure, congestive cardiac failure, dizziness. Patient may have an whitish look, is something like a pallor of lips, pallor of palms, you know. So it's you can just make out by looking at the patient. So how this particular anemia present to you? So you may going to think in terms of a very common cause is iron deficiency anemia, B12 deficiency anemia, megaloblastic anemia, folic acid anemia. I mean, folic acid deficiency anemia. Either it could be a hidden pathology, or it could be a recent patient may have a GI bleed due to some portal hypertension, due to some sort of a tumor within the esophagus, C esophagus. Patient may have chronic history of alcoholism, so esophageal varices. Patient may have an melena. He may lose the blood. Could be an bowel pathology, angiodysplasia of the bowel, ileocecal cox of the uh, bowel pathology, or ileum and cecum, which is chronically involved because of an secondary tuberculosis. Patient may have an IBD. Patient may have IBD. Could be a Crohn disease. Patient may have something, So these are how things where you may have an unhidden or sorry, hidden loss of blood. Obviously, we may face patient bleed because of a large strangulated piles, 7 o'clock, or probably long-standing piles which are not treated. They are strangulated, they are infected, they are ulcerated, and you will have a situation where the patient present to you. I think you all proctologists must have seen so many patients where hemoglobin is going down to 4.5. You have to give first transfusion, and then you do you are obviously hemorrhoidectomy, ligation of the piles, or could be a sclerotherapy, SOS, maximum anal dilatation, whatsoever. But you must keep in mind that there could be a lower GI bleed. So nutritional, lower GI bleed, immunological or autoimmune disorder like systemic lupus erythematosus, chronic liver disease, hepatitis. Basically, this hepatitis, there is a problem in iron storage. So you have an hepatitis, long-standing hepatitis, or converted into a cirrhosis, where there is a problem in the storage of the iron, and patient usually may require iron. I have 2 to 3 patients of I'm treating cirrhosis where I have to give once in 6 weeks. I have to give iron, but that iron, there are different source of irons. One is orofor. One second thing is an carboxymetallurgy, like what called as an injection NC-carb, which while is about 2,500, but we can give intravenously through normal saline slowly over 45 minutes. And after giving this particular thing, patient may feel good, patient have a good energy, patient may not feel tired. And we have seen I have seen personally, practically with Dr. Yadav. He has given Orofer's injections about 7-8 cycles, and after that, the patient is dramatically do well. It's not that, but this is what my experience with him. That's why I'm taking his name. So please mind. Okay. So it is very, very important. Whenever again we have a condition of CRF, whenever a patient, those patients who on CKD, CKD3, CKD4, where there is a problem of there is no appropriate secretion of erythropoietin. Okay, not appropriate secretion of renin as well. So all these hormones are not in a proper proper normal range within the body. Patient may going to have a load on the whole immune system, and patient may become anemic. So chronic renal failure, patient usually have a fatigability, less urine output, puffiness of the face, anemia. These are the all CKD patients. And in this thing, obviously two things you must require. You must give an injection erythropoietin subcutaneously, and obviously source of iron orally, or you can give an intravenously. So this is very important. Post chemo, obviously all these kind of chemotherapeutic agents, they may depresses your granulocytes. So you may going to have an agranulocytosis, and condition can lead to a anemia. You may require to have granulocyte raising injection. These are all important things which all medical oncologists and oncosurgeons they perform. But you must have that kind of knowledge. Your patient may have an CA breast. If a patient has CA breast, he has to undergo chemo. If a patient has CA colon in stage 2, they have to undergo chemo. And when you have a chemo, so you may going to have an adverse effect on the immune system. In order, they may face the anemia. So this is very, very important. So I'll tell you, medical practice is very, very interesting, provided you must enjoy when you see number of different variety of patients. So this is how I'm going to look at the subject. Going further, WBCs, normal count is 4.5 to 11,000 per cubic meter. There is condition, when this count is more than 13,000, 12,000, we condition called as leukocytosis. So usually when the count goes more than 13,000 up to 20,000 leukocytosis, and patient may have we are, in our mind, we have only 2 to 3 findings. One is patient ko infection ho gaya. My friend, I agree with you. Patient may have an infection, but why there is infection? So there is a leukocytosis for 3 reasons. There is a demargination of the WBCs within the cell, which is 60%, which can cause leukocytosis. Second thing, a delayed migration. 30% of the WBCs of delayed migration within the cells, within the tissues, and 10% band, released from bone marrow, that is neutrophil, lymphocyte, and monocytes. So these are the 3 important pathophysiological factors which can cause leukocytosis. And what could be the probable etiology? Infections. Could be a pyogenic, could be a bacterial. If you think in terms of bacterial, could be pneumonia, could be urinary tract infection, Neisseria gonococci, meningitis, cholecystitis, diverticulosis of the colon. And when you have some sort of an acute infection, you may going to have patient presented with fever, pain, swelling to a respective side. So you may going to have an infective foci, and with this kind of a symptom, you have a WBC count. So if you have a pneumonia, you get an X-ray chest. If you suspect a UTI, you do urine routine microscopy. See, pertaining to that, you go further with your further investigation. You suspect UTI, do urine routine microscopy, do creatinine, do biochemistry, do urine culture, antibiotic sensitivity test. If you suspect meningitis, obviously you do a lumbar puncture. You suspect cholecystitis, you do an USG abdomen, upper abdomen. You do an LFT. You suspect diverticulosis of the colon. Obviously, you settle the patient. Obviously you go for a stool examination. You will go for an certainly colonoscopy. So you have a role of many investigation, so many investigation, provided you think logistically pertaining to a baseline investigation, what it gives clues to further elaboration of investigation and further elaboration of the mode of arrival of diagnosis. Going further, of hospital-acquired infection. This is very, very common, not here, but in the United States, where a patient is admitted in the hospital due to some sort of a surgery of some hip replacement or some spine surgery or some brain surgery, and he may land up with an this kind of an hospital-acquired infection of Clostridium difficile, where your WBC count goes to 30,000, 40,000, 50,000. So when you suspect such things, always get done a CT abdomen very fast. You may going to see a bowel thickening. You may going to see a bowel thickening. You may going to have a fat standing along with the large bowel or mesentery. So you may going to have this kind of a thinking of Clostridium difficile, where a patient may develop an diarrhea or something. So treatment of choice, drug of choice is injection vancomycin. Injection vancomycin has to be used judiciously with respect to serum creatinine level. If you give too much vancomycin, patient may precipitate renal failure, and obviously IV metrogyl. Another important thing which you must have seen in practice, patient on long-term steroids on prednisolone, especially those who are bronchial asthma, those who have rheumatoid arthritis, those who may have COPD, exacerbation of emphysema. Those patients may going to have high WBC count, leukocytosis. So patient may have a long-standing steroids taking, they may going to have leukocytosis. Going further is certain amount of alarming conditions like cancers, leukemias, lymphomas, where cell doesn't die, where the cell doesn't die within this WBC, they may going to have something called as myelogenous activity. They may going to have an myelogenous activity, especially an acute lymphatic leukemia, chronic lymphatic leukemia, acute myeloid leukemia, chronic myeloid leukemia. So in basically AML and CML, this myelogenous activity, when you suspect where there is a WBC count is more than 40, 50, 60,000, you ask your pathologist. You must have all friends around, a good pathologist, good anesthetist, good radiologist, good intravenousist, good urologist, good physician, good proctologist. You see? So I think if you have a good pathologist with you, they may going to have a peripheral smear, and they have an atypical cells. They have atypical cells, which is a diagnostic and pathognomic feature for an acute myeloid leukemia, which required a bone marrow biopsy. And bone marrow biopsy will confirm that that is an acute myeloid leukemia and chronic myeloid leukemia, and the only mode of treatment is bone marrow transplant. So, diagnosis is very, very important, and it is very simple, provided you have a common sense and provided you have a clinch to the diagnosis. Going further, sometimes you may going to have a patient present to you in your casualty, to breathlessness, or could be a bradycardia, perspiration, anxiety. What is that? Or maybe a sullen face, a very anxiety, anger, anemia, anxiety of death. So all these patients are present in what? They present in cardiac department. So usually these are all catastrophic events of myocardial infarction, pulmonary embolism, or post-surgery. In those conditions, if you do an CBC immediately, a leukocytosis. Even now, this is a summer going on. You go for a cold bath. You go for a cold shower. And when you have a cold shower, there are cases reported. You do a CBC immediately after that, you may go to have a leukocytosis. So this is very common. If you want to prove this, you go for a nice cold shower bath and immediately you go to a pathological lab and give a sample. Your WBC count is on the higher side. So you must understand what is normal and you must understand what is abnormal. So if you have MI, if you have pulmonary embolism, and you see CPC, then you think in terms of, no, this patient may have an acute infection. No, this is a metabolic breakdown, where there is something which is a problem as far as the WBC leukopoiesis, where there is too much immature WBCs which may form. Okay, now this is what we talk about leukopenia. What about leukocytosis? Now we are going further with the low WBC count. So when the count is 1 to 2,000 or 2 to 3,000, we call it as leukopenia, or count below 4,000. And what are the important causes? Viral infections, dengue, very, very common. COVID-19 situation, influenza, and HIV infections. So when you have always leukopenia for long standing, about 2,500, 2,800 WBC count, and patient is not doing well, oral candidiasis, you may examine the patient, you may feel the inguinal lymph node or axillary lymph node, just send the sample for HIV, Western blot, and patient may come HIV positive. And when you have this situation, you must go for a CD4 count. You must have a CD4 count, which is the pathognomic feature, which is a very important diagnostic tool. When the CD4 count is more than 200, it's confirmed that patient has acquired immunodeficiency virus, or human immunodeficiency virus, which is a long-standing pathology, but still there is a treatment going on, and people, I don't have that much experience. I'm not a virologist, I'm not an immunologist, but HIV can have a leukopenia. Obviously, aplastic anemia, where there is a problem, especially within the bone marrow, where the bone marrow itself has a genesis or tumor, we have an aplastic anemia. Myeloproliferative neoplasms, some hematological neoplasms, ongoing chemotherapy for cancers, and drug induced. Usually, in all general practitioners, they have trained to give a bacterium, they have trained to give sulfur drug, they have trained to give, this trimethoprim drugs. So these are all which can cause leukopenia. Going further is differential count. Differential count and neutrophilia. So when you have a neutrophilia, obviously I told you already 60% of the infection is because of pyogenic or bacterial. When the count is more than 13,000, active treatment is necessary. And if it is more than 20, 30, obviously you have to admit the patient as early as possible and give either you can do a blood culture in order to isolate the organism and give specific antibiotic, or try and source the other area of source of infection. Eosinophilia. When you have eosinophil, usually eosinophil is 1 to 3, but if it is more than 3 to 4, 4 to 5, you must going to have a parasitic infestation of hookworm infestation, ankylostoma duodenal, filariasis, where patient may have an parasitic infestation, allergy, drug induced, some sort of a fungal infection, coccidioidomycosis, polyarthritis nodosa. In all these conditions, where eosinophil count is on the higher side. Going further is your lymphocytes. When your lymphocytes is more than 18, 20%, you suspect a viral. And what is viral? Is obviously today's era is COVID-19 situation. So when you have a lymphocytosis, when you have a leukopenia, you ask for CRP, C-reactive proteins. So when you have C-reactive proteins on the higher side, lymphocytosis on the lower side, leukopenia, obviously you must go for a HRCT, high resolution CT scan, in order to see mild, moderate, severe cases of COVID. You see, where there is how much amount of consolidation, how much amount of interlobular thickening, whether how much amount of pulmonary fibrosis has been established. So it is very, very important, that how you can think about it. So could be a viral, could be a tuberculosis, monocytosis, again viral, tuberculosis, and a chronic inflammatory condition. Chronic inflammatory condition like Crohn's disease, ulcerative colitis, polyarthritis nodosa, rheumatoid arthritis. In all these things, you may see there is a chronic inflammation going into the background. Even in infective endocarditis, where there is a endocardium is chronically inflamed. See, so monocytosis, basophilia. When there is an immature basophils, too much amount of basophil, more than 4 to 5%, usually it's 0 to 1%. So allergy, chronic myeloid leukemia, Hodgkin disease, and some females, those who are taking oral contraceptive pills, always look at the basophil. They may going to have 2 to 3 basophil. That means they have an obesity. They have disturbed their cycle. They may going to have arthritis, some pain. These are all hazards, and these are all side effects of estrogen. Taking too much amount of estrogen, which disturb the cycle and which disturb the metabolic functions as far as the hormonal axis is concerned. Very important, platelets. Platelets normally help to heal the cut on the skin and mucosa. This is a basic primary. Why? Because whenever you get something, always, you never bleed so much. Immediately it stops. Why? Because there is a platelet aggregation. So platelets they always achieve the hemostasis. Or they always aggregate there and stop the blood. You see, they stop the source of further bleeding. You see, so usually in gums, nose, GIT, so protection from bleeding. That is a basic function. So when platelets drop significantly, how we determine bruising, gum bleeding, epistaxis, heavy bleeding during the menstrual cycle. And when the count below 40,000, usually count is 1.5 to 4.5, or 1.5 to 4 million per cubic millimeter. Okay, sorry, 1.5 to 4 million, yeah, 4 million, so 1,50,000 to 4 lakh, 4 lakh, 4 lakh cubic thousand cubic millimeter. So when you have this kind of a thrombocytopenia situation, where the actually when the platelet is go below 40,000, chances of bleeding is very high. And all such patients, you should not do any musty. You should always admit the patient in the hospital and keep under observation. Either you may require to give a direct platelets, axial volume, or SOS, whatever there is a pathology. So thrombocytopenia, heavy thrombocytopenia could be a malaria, could be a dengue, viral, leukemia, rheumatoid arthritis, septicemia. Patient may have diabetic, they have not treated in time. Suddenly patient deteriorate, septicemia, or you may operate it and some sort of a secondary infection. Patient can go into septicemia, SLE, IBD, thrombocytopenia. Thrombocytosis, when there is a too much amount of platelets, could be a myelofibrosis and central thrombosis, which will lead to a clotting and subsequently bleeding. Central thrombosis means what? It disturbs the cytokine mechanism within the blood. And the current situation is obviously COVID-19 situation. Okay. Going further, I know it's maybe a boring for you people, but now what to do? I have to give you something which is baseline. Red cell indices. What is MCV? Mean corpuscular volume. Now, how I remember the size of the RBC. Basically, it's the size of the RBC. So it is when the RBC low in size, you think in terms of iron deficiency anemia. If it is high or bigger in size, big RBC, you see in under microscope, B12 deficiency, dysplasia, or multidysplastic syndrome, or medication. You see, so when the you see RBC big more, you may think in terms of B12 deficiency, dysplasia, medication. Second component, MCH, mean corpuscular hemoglobin. Mean corpuscular hemoglobin. What do you mean by this? How much amount of hemoglobin which is within the per cell? So when MCH is low, again iron deficiency anemia, again thalassemia. But when it is high, then you may think in terms of red cell membrane disorders. So usually if you see in all MCV also iron deficiency common, low in means MCH also iron deficiency common. Again going further, MCSC, mean corpuscular hemoglobin concentration. Again, if it is MCSC low, again there is very common in iron deficiency. So iron deficiency anemia is so common. If you can just replace the IV oral orofer or iron, patient can revert back to normal very fast. So such a normal situation in the community, in medical practice. So you must think in terms of all these markers. And obviously, this MCSC is high in small circular, where there is a cells are small, especially or they are very immature, be that cells we called as spherocytes. So these are all things they are basically see we look into two conditions, is hereditary spherocytosis and hemolytic anemia. You see? So basically, what I feel, anemia is very common in clinical practice, mainly due to iron deficiency anemia, B12 deficiency, folate deficiency, thiamine deficiency, and renal failure. CKD patients. See, if you just give iron, if you just give orofer, or if you just give erythropoietin subcutaneously, I'm going to give you the dose. Patient may thrive well, and patient may get used to normal lifestyle. But if you don't load them with the iron, patient may go have a long-standing illness, and the complication rate is on the high side. Early 20 to 50% function remains. Kidney synthesis erythropoietin, as I mentioned to you, stimulates the bone marrow. Diseased kidney do not produce EPO. Treatment is EPO is 2000 international unit, 5000 international unit, 10,000 international unit. Depend upon the how much is amount of their hemoglobin and creatinine level. If the creatinine is more than 5.66, you can give 5,000 international. If creatinine is more than 7, straight away you can give 10,000 international unit and just wait for 2 weeks of time, because this particular erythropoietin action may remain for 2 weeks. So in a month you can give two injections subcutaneously, and which can lasting effect to produce erythropoietin and stimulate the bone marrow and increase your iron load. So this is how, and your target in CKD patient is keep the hemoglobin is 10 to 12 gram. See, gram percentage. So going further is renal function test. Each kidney has more than 1.2 million nephrons, which is a function in it. Now, what is the basic renal function? It filters and processes the blood to form the urine, regulates the fluid and electrolyte balance. Third, waste substances like serum creatinine also filtered, but it goes out of the body also through urine. Synthesis of 3 hormones like erythropoietin, which stimulates the bone marrow RBC formation. Renin, which stimulates the renin aldosterone mechanism, and you maintain your blood pressure. That's why renin has a direct effect on your arterial pressure. An active form of vitamin D ensure the calcium is absorbed from the food what we eat. You see, so this is how basic renal function is. And when these functions get altered, you'll end up with some sort of symptoms, and those symptoms you have to do investigation and prove clinically. Now, what are they? Electrolytes. Now, electrolytes level are affected by certain things. How I'm looking at how much you take in, how much amount of fluid you have been taken inside. Second thing, amount of water in your body, very important, because sodium, potassium, these are two important parameters. They have an important role is your intake and your water inside the body. Then how much amount do you excrete? That is also important, depend on diseased kidney. And you can also lose electrolytes normally in your stool and sweat. So if you know your basic, then it is very important to replace either as potassium or to replace either sodium, depend upon the need of the body. And again, aldosterone, which is a hormone which stimulates the adrenal gland, which liberates from the adrenal gland, which has direct action, which promotes the sodium reabsorption, absorption, and potassium excretion and hydrogen ion by the kidney. Now going further is sodium. What is the normal sodium level? 135 to 145. If it is below 130 or 132, patient may going to talk about confusion in the mind, blood, very sluggish talk, blurred vision. So all these signs of hyponatremia. You see, so major positive ion. This is a major positive ion in the fluid, outside the cell. Okay, which is a major positive ion in fluid outside the cell. And brain, muscles, and nervous system depend on this electrical signal. Sodium is very required for to muscle, for brain, for electrical signals. And whenever there is a movement of sodium from the cell, it is critical for the electrical signals. And therefore, increased sodium or decreased sodium causes cells to malfunction, and which can be a fatal. Now, what is that? Could be a hyper or hypo. So hyponatremia, excess water in relation to sodium. If you take too much water also, there is a problem. Chronic liver disease, hyponatremia. Cirrhosis of liver, hyponatremia. Congestive cardiac failure, hyponatremia. Excessive water drinking, hyponatremia. So especially if you have some alarming condition in the background like liver disease or kidney failure. Now hypernatremia. Usually you have to be very cautious, especially those who have a cardiac element, hypertensive patient, where you must restrict the salt. Because if you have already arterial pressure, there is a lot already sodium is getting reabsorbed, and increase in intra-arterial pressure, increase in cardiac output. Then if you take more amount of sodium, it may shoot the pressure. And if your blood pressure gets shoot up, you may going to have consequences like MI. You may going to have consequences like an cerebrovascular accident. So many remote complications because of hypertension. Don't take hypertension very lightly. Hypertension can ruin the life, and patient can become bedridden. You know, I have in my life, I have in my life spent my miserable 4 years of life when my mother is got sick, and we, either she may not address us, or she didn't inform us, or probably delayed to start an antihypertensive, and she landed up with a hemiplegia and global aphasia. But this is what very unpardonable and very, very disturbing for the family members. Going further is potassium. Is 3.5 to 5 is what is the action? It is a major positive ion within the cell. Now, potassium found in many foods. Potassium is also excreted mostly by the kidney. 90% of the potassium is excreted by the kidney via urine. Only 10% potassium is excreted by the GI tract. Very important. 90% by kidney, 10% by GI tract. So whenever there is a problem in kidney and GI tract, obviously you may going to have an hypokalemia, isn't it? So small amounts in sweat. So aldosterone, also potassium regulation, excretion by kidney. Now see, importance of potassium level. Why? It regulates heart rate, and because it has direct action on the heart rate. Because it has direct action on your SA node, your AV node. That's why if a patient may have an hypokalemia, patient may immediately land up with an atrial fibrillation, arrhythmia. So you may going to, because it disturbs the contractibility of the heart, where the heart is your pump, your heart get pump is more than 140 per minute. You see, it's something like that. So you may have an R wave irregular and P wave absent. P wave absent, R wave irregular, potassium is on the higher side, atrial fibrillation, spot diagnosis, ACE. Okay, and you may going to have a muscle function. So potassium is directly, because your muscle to contract, you require potassium within the cell. If the potassium is go outside, the muscle become very flabby, and patient may going to have an act in the lower limbs, and that we call a pseudomuscular paralysis. In basically, there is no paralysis, but patient may going to have a weak and paresthesia within the limb. Is what? Because of you lose the potassium. See, very, very simple. Electrolyte imbalance is, you have to just keep in very common sense, and you may hit the problem. So what I assume, if the potassium is below 3.5, it's a low zone. It's a hypokalemia. If it is in between 3.5 to 5, it's a safe zone. But if it is up to 6, it's a cautious. One has to be cautious. And if it is more than 6, then it's a danger zone. And only one condition when there is hyperkalemia, where the potassium is not get excreted out by the kidney. 90% of the potassium has to be get excreted out of the kidney. But when the kidney is not able to function properly, especially a chronic glomerular nephritis, especially acute glomerular nephritis, nephrotic syndrome, a renal failure, chronic renal failure, where the potassium is getting accumulated within the blood, and patient may have an hyperkalemia, and which has direct effect on the heart, and patient may going to have an rhythm disorders. So basically, hyperkalemia is because of renal failure. Again, very important cause. Again, patient may have a crush injury. Patient may have road accidents. You may have road accident and crush injuries. There is a rhabdomyolysis, muscle breakdown. You see, muscle, when the muscle is get teared, within the muscle, there is a protein breakdown and the potassium is get lost. So rhabdomyolysis, adrenal failure, addition disease, secondary hypoaldosteronism. You see, so adrenal failure, addition disease, drug induced, AC inhibitors. Usually, general practitioner very important. They have to start losartan, they have to start enalapril, captopril in olden days. Nowadays, we have good drugs like telmisartan. Now we have good drugs of vardenafil. We going to have an almosterone. But all these AC inhibitors like losartan, enalapril, captopril, they may going to have a hypokalemia situation. Diuretics also. Patient is on renal failure, we give spironolactone. But at the same time, you may lose the potassium. Sulfa group of drugs. Now, hypokalemia also. So this is what we talk about hyperkalemia. Hypokalemia, poor intake, loss from GIT. What is GIT? GIT causes vomiting, too much amount of vomiting due to some food poisoning, diarrhea, some sort of an abdominal infection. You see, laxative, too much constant use of laxative in older people. Crimaphin plus, like getting crimaphin plus for years and years, and you may going to have an hypokalemia because then they said पैर में दर्द हो रहा है, मेरे को बहुत easy नहीं है, मेरा बहुत थकान जैसी लग रही है. You do potassium, they may have potassium free, and you give nariyal pani to them, you give syrup pot chlor, or you give something, potassium replacement, they feel all right. What is that? It's just your replacement of a potassium by giving certain substance. Excess of aldosterone, excess of chloride bicarbonate. It's okay. Let me go further. Now, this is very important. I must address, I think, you see, GFR. Normally, kidneys filter 180 liters of blood per day and 1 to 2 liters of urine, and 90% reabsorb into the blood. Composition of urine modified by secretion and reabsorption. In clinical practice, the plasma concentration of waste products such as creatinine and urea are used to estimate the renal function. Therefore, very important that BUN, normal BUN level is 6 to 24 mg per dl. But this BUN usually it's produced in the liver when there is a protein breakdown into amino acids. So mind you, if you have a liver injury also, long-standing liver injury, chronic liver disease, hepatic encephalopathy, cirrhosis, still your urea also goes high because urea primarily get produced within the liver. So urea is released into the blood where it is filtered and excreted by the kidney. So if you have a significant kidney failure or liver failure or hepatorenal shutdown, your urea goes high, your ammonia goes high. So mind you, you have to keep in this particular basic format. Therefore, this condition can affect liver and kidney and increase in urea levels. I have estimated certain things. Usually, your GFR is 175 ml per hour. You see, 175, 160 ml, 160 to 170 ml per minute. Sorry. So CKD stage 1, when you have a GFR is in between 90 to 120 ml per minute, that is stage 1. When the GFR reduced 60 to 90 ml per minute is stage 2. When it is 30 to 60 ml per minute is stage 3. When it is 15 to 30 ml, stage 4. And when it is below 15 ml per minute, stage 5, that is we called as end-stage renal disease or renal failure. So BUN, when BUN get increased, end-stage renal disease or established renal failure. Renal ischemia, you may go to have a less renal blood supply due to congestive cardiac failure. Severe dehydration can lead to an acute tubular necrosis. Severe dehydration can have an acute, because there is a acute hypovolemia can lead to an acute tubular necrosis, and if this acute tubular necrosis, which can cause diffuse necrotizing papillitis and can lead to increased urea and creatinine level markedly. So acute kidney injury have more increase in creatinine and urea level because sudden insult. Could be a dehydration in the form of vomiting, diarrhea, or whatsoever. GI bleeding, increased catabolism, protein breakdown on steroids. So BUN also decreases in severe liver diseases and malnutrition. You see, when there is a liver failure. See, creatinine. So normally creatinine is male is 0.7 to 1.3 that's a normal variant in male. In female 0.6 to 1.2. But what I want you to remember, if you have a good muscular young adult, he may have a good, he may going to have a 2 creatine. Creatine is more. That doesn't mean that he may going to have some sort of illness. That is just his bulky muscle mass. You see, but in elderly, they are all emaciated, thin. So you may going to have a less creatinine. That doesn't mean his creatinine is normal. If you have a 90-year-old man, you see creatinine is about 1, I feel that his creatinine is not 1. According to me, his creatinine is more than 2 or 1.9 or 2.1. That means he has already raised creatinine. You see, so don't go on only on prediction of values. Think a basic physiological background. You see, to produce continuously from, because this creatinine usually produced from muscle breakdown, and kidneys filter creatinine from the blood into the urine. Amount of blood that is cleared from the creatinine each minute is called creatinine clearance and is a good estimation for GFR. Good. As you are all aware, no urological examination is get fulfilled just by doing and without having a report of a urine examination. So you have 3 criteria: physical examination, chemical examination, microscopic examination. You must have a look at the color. What is the color of the urine? Either it's a red, yellow, orange, black, whatsoever. Depend upon you think in terms of diagnosis. Odor, foul smelling, fishy, or whatsoever. Sweet color urine, sweet like smell. You see, especially in diabetic ketoacidosis, foul smelling urinary tract infection. Specific gravity 1.003 to 1.0025. If it is too low, renal failure. You see, pH is 7.3 to 7.5. An appearance of the urine, whether it's a turbid or cloudy, you may see sometimes white color urine. Why? There is a condition called as chyluria. See, so this is how you think in terms of chemical examination. Usually, all these things, if there is a protein, that means obviously there is a proteinuria, glucose, patient is not treated properly, patient may have hyperglycemia, ketone bodies decay, bile salts, patient may have obstructive jaundice, bile pigment, patient may going to have an medical jaundice, obstructive jaundice or hepatic jaundice. Patient may have occult blood, that means there is something bleeding from the urinary tract, either from the above or from the below. Microscopic examination, RBCs, microscopic hematuria, think in terms of identify the cause: kidney, ureter, bladder, urethra. WBC, if it is more up to 5 to 10, it's considered normal. If it is more than 40, 50, we consider it's a pyuria. So could be infection, could be long-standing chronic inflammatory condition, could be tuberculosis, sterile acidic pyuria, could be lymphomas, could be VUR, vascular-ureteric reflux, could be long-standing parasitic infestation like a bilharziasis of the bladder, could be neoplasm, tumor, neoplasm within the bladder. So long-standing pyuria. So or could be a non-function kidney. So pyuria also is a very long, it's a different thinking altogether. Too much cast. Either there is too much cast, obviously we think in terms of glomerular pathology. We think in terms of glomerular pathology. If it is too much epithelial, think in terms of tubular pathology. If it is too much amorphous material and cast, patient may have blood pressure, patient may be developing renal failure, bacteria, infection, mucus rate, some sort of a this thing. Spermatozoa, obviously you may going to have an retrograde ejaculation or something. So proteinuria is the first sign of kidney disease, is to be measured by either by a dipstick method or by urinary albumin creatinine ratio. Normally, if it is more than 30 gram per G, it's an abnormality. If it is in between 30 to 300 milligram, okay, per gram, it is a what we call as a microalbuminuria. But if it is lost, if you lost more than 3 gram per day, that means the patient may already leaking too much amount of protein through the urine sample. That means there is a established renal failure. And when you have a protein loss, patient is going to have other symptoms. It may going to have collection. You may going to have puffiness of the face. You may going to have edema, swelling. All this kind of. Then you're going to have change in the constituent of the blood. Collection of the fluid into the interstitium. All these causative factors comes in terms of as well as the load on the extracellular space. So basically, patient may have, you know, I can say too much amount of loss of proteinuria is a basically a early sign of to detect the damage to the renal area. But there is something condition we always face, that patient may born with multiple cysts within the kidney, not a single cyst or two cysts. That is called as autosomal dominance polycystic kidney disease, where you may also get, where we also get proteinuria, but this ADPKD is not usually associated with the nephrotic range of proteinuria. It's just because of intrinsic pathology within the secretory system of the kidney. So ADPKD proteinuria, the reason is different, and the injury to the kidney, either by infection, either by immunological problem, either by diabetes, either by hypertension, either by drugs, and that comes under the category of nephrotic. I think this is a bone lab. We must have understand the calcium. Normal level is 8.7 to 10.2 mg per dl. Serum phosphorus level is 2.5 to 4.5 mg per dl. But it relates to renal failure from stage 3 to 4 CKD. You may going to have stage 3, stage 4, where there is too much phosphorus. So when you have too much phosphorus in the blood, it may increase the lipase activity, and patient may indirectly going to increase the triglyceride. So you may going to, that's why we wanted phosphorus to be on the lower side. If you have if the phosphorus is low, then your cholesterol will not, or your triglycerides will not go high. So active form of vitamin D also decreases. So phosphorus increase in the triglyceride, altered lipid. So this results into basically renal failure, basically into low calcium, stimulates renal failure into low calcium, stimulates parathyroid gland to secrete parathyroid hormone in order to absorb more calcium from the bone, and that we called as secondary hyperparathyroidism. And if you absorb more calcium from the bones become more brittle, weak, and prone to get fracture. Therefore, estimation of parathyroid hormone in renal failure is mandatory. And what you just to do when you have a renal failure patient, you give something to decrease the phosphorus level, a tablet low phos, or you may go give something exogenously, is 125 hydroxycholecalciferol or 125 vitamin D replacement therapy is very important. That's why we give injection architol 60,000 international unit once a week, or especially renal failure patient, initially twice a week, and then later on once a week for 2 months or 3 months. I think is it permissible to me to go ahead, or should I stop here? Should I start here, or should I continue? Should I continue, or just for LFT? Because my
can you stop with this?
Yes. I beg your pardon. I didn't heard you.
Sir, we have next.
Okay, fine. So I think I should wind up my certain slides. Actually, I have a good preparation on LFT, but now, sorry. See, I have made certain profiles. If you have a fever, you must do a CBC. You must have ESR, MP, Vidal, HGPT, urine, reactive protein, LDH. If you suspect a DM and you have a sugar, you must get it done CBC, HbA1c, urine for microalbumin, lipid. If you want to suspect a cardiac injury, CBC, ESR, LDS, CPK, CPK-MB, lipid, D-dimer, very important. You suspect high, it may give an indication about how your pulmonary status, ECG, X-ray chest, serum homocysteine level, very important as far as the cardiac injuries are concerned, and serum TSH. Very important. When you're suspecting neoplastic pathology in male, I must feel alpha-fetoproteins, CA levels, beta SCG, CA level for CA colon, beta SCG for testicular cancers, alpha fetoproteins for liver cancers, serum PSA for prostatic cancer, CA 99.9 for pancreatic cancer, thyrocalcitonin for thyroid follicular thyroid carcinoma, thyroglobulin, and so on. If you suspect a neoplastic pathology in female, alpha fetoprotein, obviously, especially in liver metastasis, CA colon, SCG, obviously, some chorion or placental malignancy, or obviously reproductive malignancy, CA 125, CA ovary, CA 19.9, pancreatic malignancy, CA 15.3 is breast malignancy, calcitonin, thyroid malignancy, thyroglobulin, thyroid malignancy, and pap smear. Very important issue in gynec practice for pap smear. Now, somebody wants to marriage, and what they must undergo investigative profile. Is pre-marriage in profile in male, CBC, fasting sugar, blood group, triple H, HIV, HbAg, HCV, VDRL, urine routine microscopic semen analysis, and hemoglobin electrophoresis in order to see is there any problem of abnormal hemoglobin of thalassemia major, thalassemia minor, hereditary spherocytosis, all such things, megaloblastic anemia. So you must going to think in, because people may ask you, "Aapka blood group kya hai?" So you must have this data when you want to stand in the mandap to go for a marriage. This is same calculation with female, is CBC, fasting sugar, urine routine, triple H, VDRL, blood group, and hemoglobin electrophoresis. Is because they face a difficulty when they go for a issue, and and they may go to have a threatened abortion. Or maybe we go for an anomaly scan, and patient may go to have a phallostatology. Patient may have pulmonary atresia. All these kind of defects which may going to get into the baby when you have some blood group disorders. Now, very important, female infertility issue, that AMH, anti-Mullerian factor, inhibin B, and ovarian antibody. And male infertility, serum FSH, serum LH, serum TSH, prolactin, testosterone, semen analysis. Obviously, post-ejaculation urine, those patients who's on alpha blocker, those patients undergo some sort of an transurethral resection of the prostate surgery. They may not able to ejaculate the sperm while the normal act, but after the act, when they urinate, they may come to have a lot of sperm within their urine sample. Again, anti-sperm antibody, sperm DNA fragmentation test. Obesity, very, very happening issue all over the world, is you must going to have a thyroid function test. Most of the female, they may go to hypothyroidism. Fasting sugar, their lipids get altered, electrolytes, creatinine. You must do a cortisol level in order to find out a Cushing syndrome, uric acid level, serum phosphorus, urine, and obviously insulin. And all this kind of an obese patient, they're going to have an insulin resistance. Sorry to take you long. This is exactly every time it happens to me, because I required to talk too much, because I wanted to give to the crowd much, and this is with my best capacity. Thank you so much for kind listening and giving me an opportunity to deliver such a few nutshell about how to go with the investigations. Thank you.
Thank you so much.
Yeah, thank you.
Yeah. Thank you, sir, for sharing your knowledge with us. On the behalf of Fiela Ayurvedic Medical College and privileged audience, I thank you on everyone's behalf for your graceful words. Looking forward to many more opportunities to grasp knowledge from you. Thank you each and everyone for your interest and support for today's session. Thank you, sir.
I appreciate it. Thank you very much. Hello.